Good afternoon, good evening from wherever you're joining us. My name is Mariam Bakhtiari. I'm a pediatrician with a huge passion for neonatology and neonatal neurology, and I'm very excited to be here today to moderate this session with Newborn Brain Society. So this session is actually very dear and near to my heart because this session is being presented from my home country, Iran. So the two presenters are actually coming from Iran, and I am super excited for that. But before we start our presentation and our event, so there are a few updates that I want to share with you just to know. So first things first, don't forget to check out the Volpe's View on the Newborn Brain Society website. They are really great. So this is the second one, and the first one, I think it came out like 2 months ago. And this one, and that one was about HEAL trial, and this one is about preterm infants and their sleep patterns. And they are specifically written by Dr. Volpe for Newborn Brain Society, and they are priceless. So don't forget to check them out. And also for members interested in serving the Newborn Brain Society community and the committees, so you can nominate yourself or others. So you can learn more about this using the QR code that is available here. And the next thing that I want to share is actually the teaching modules that are available on the membership portal. So once you're a member in Newborn Brain Society, you have access to the educational modules that are presented there. So there are the recordings of the webinars that have been presented during the years before in the Newborn Brain Society, and they are grouped around specific themes. So for your interest, and they can be used for general review, test prep, or supplemental training courses. And the available courses right now are actually neonatal seizure, preterm brain injury, fetal brain development and injuries, neonatal cranial ultrasound, which that one is my favorite, and also AEG and EEG trends. So you can access them once you're a member, you can access them through your membership portal. You just have to log in to the website. And the next thing that I want to share is actually the upcoming webinars. So next week, we have a nursing webinar. The topic will be sucrose analgesia for preterm neonates. Then the next week, we will have a quality improvement webinar talking about tertiary white matter injury and circadian disruption after HIE at preterm gestation. And then we will have the next webinar will be shining light on the newborn brain beyond nurse. And I think these three will also be super interesting. Okay. And one exciting news also that I have. So we passed IMBBS last week, which I'm sure most of you attended, and it was super great. So this time we're going to have the PASS meeting. So PASS is happening from May 2nd to May 6th. And it is happening in Toronto this year. And we have MBS meet and greet breakfast as always, as every year. So it is an exclusive networking opportunity featuring a prestigious ceremony to honor the MBS 2024 Honorary Fellow, Dr. Alistair Gunn. And the timing will be on May 4th from 6:30 a.m. to 8 a.m. So you can actually access this event with your past registration, but you have to RSVP for this event. So use the QR code that is presented here. And then there are also some quality improvement resources available on the portal and on the website, so you can definitely check them out. And then without further ado, I would really love to start today's presentation, as I told you before. So the topic will be neonatal metabolic encephalopathy, and the people presenting this are actually two of my dear professors from Tehran University of Medical Sciences, Dr. Mahmoud Mohammadi and Dr. Zahra Rezai. Okay, so I will just give you a very brief biography just to get to know them. So Dr. Mahmoud Mohammadi graduated his medical school and also his specialty from Beheshti Medical School. He also obtained a subspecialty degree in pediatric neurology in 1991. And then he also had a 1-year training in pediatric clinical neurophysiology at Great Ormond Street, London. And then he also had an 18-month training course in pediatric epilepsy at the Hospital for Sick Kids at Toronto. And he is currently a full professor at Tehran University of Medical Sciences in the neurology department from the pediatric ward. And then we have Dr. Zahra Rezai. So Dr. Zahra Rezai completed her medical training in pediatrics in 2014 and did her subspecialty training in 2019. And she also finished her fellowship in clinical neurophysiology and epileptology last year. And besides medicine, she earned a master's degree in medical education from Tehran University of Medical Sciences. And right now, she's an assistant professor of pediatric neurology, also from Children's Medical Center from Tehran University of Medical Sciences. So Dr. Mohammadi and Dr. Rezai, we are more than excited to hear what you have to offer us, and we can't wait to listen. The stage is all yours.
Thank you so much, Mariam, and I'm very happy to be among you. And today, discussion is about the neurometabolic disorders and neurometabolic encephalopathy of the newborn. But as you know, it is a very large and big issue to discuss in detail. So we are going to present some cases in from the neonatal neurometabolic encephalopathies, as well as some important points on this issue. So I am inviting Dr. Rezai to present the cases, please.
Dr. Rezai, I think you're mute. I think you are mute. No, not yet. Yeah. Okay, good.
Yeah. Greetings, good morning, good evening, and good afternoon. It's my honor to participate in NBS webinar training session. Actually, I would like to extend my heartful thanks to Julia and Mariam for all their support and kindness. To make the most internet bypass usage, I have to turn off my camera during presentation. Mariam, is my screen shared?
Yes, we have it. Yeah, that's great.
Okay. Thank you. The topic of the presentation is neonate with metabolic encephalopathy. Okay, I have no actual or potential financial interest or relation to be disclosed. And about outlines, we're going to review the history of 3 cases presented with seizure and encephalopathy. These scenarios take place in different places, I mean intensive care unit, neonatal ward, and a neurology office. It means that these patients could be visited in completely different situations with completely different severity. On the other hand, cases are designed in order to frequency from the most frequent to less. It means that the first case could be happened in everyday practice and misdiagnosis could lead to permanent damage. Differential diagnoses are considered in cases, and we're gonna to highlight the key features that are useful to make the correct diagnosis in similar condition. Each slide contains brief data of history, physical or neurologic examination, and paraclinic evaluations. You could think about the case and make your hypothesis quickly. After the main lecture presented by Professor Mohammadi, we will return back to cases and study them in more details. And finally, key features will be summarized as highlighted clinical clues in neonatal metabolic encephalopathy management. Okay. The first case, you are called to visit a low birth weight neonate a few hours after delivery in neonatal intensive care unit. She suffers from irritability, high-pitched crying, exaggerated motor reflex, and seizures. Mother used multi-substances during pregnancy and just before delivery with no appropriate and regular care during pregnancy. However, ritodrine hydrochloride was prescribed several days ago to prevent preterm labor. And now, what are you thinking about the diagnosis? Is neonatal abstinence syndrome the best diagnosis for this neonate? The second case, neurologic consultation is ordered for a 3 days neonate with uneventful pregnancy and full-term delivery. She was born to a consanguineous background. Myoclonic seizure, poor sucking, vomiting, hypotonia, and apnea lead to mechanical ventilation are the main clinical picture. Blood glucose, electrolytes, and CSF analysis were normal. And what are you thinking about this case? And the third and the last case, you are visiting a 1-month twin due to frequent seizure. Past history shows a 36 weeks gestational age, uneventful pregnancy and delivery with no NICU admission after birth. Parents are paternal cousin, and the older offspring is a 4-year-old healthy boy. Seizure started a few days after birth with different semiology, with no response to medication. A brain MRI that was ordered by another physician is available. Here you can see the brain imaging. And what are you thinking about the diagnosis? Is hypoxic ischemic encephalopathy the diagnosis as the main cause of neonatal encephalopathy? Let's go to the main lecture presented by Professor Mohammadi. We will return back to the cases soon. I'm handling the session to the host.
Hello again, and good morning to some part of the world, and good evening and good night to the other parts. And let's have the screen share. Is it clear now?
Yes, Dr. Mohammadi, it's clear.
Okay. As I said before, the non-metabolic causes of encephalopathy in the newborn is a very big issue. So I'm going to talk about some important points on this issue. I have no disclosure. The objective of discussion is that at the end of the session, you are supposed to be to explain about the commonality of neonatal metabolic encephalopathy with the more common neurological disorders in this age group, name at least 2 neonatal metabolic encephalopathy mimicking hypoxic ischemic encephalopathy, and describe encephalitic crisis in a neurometabolic disorder. The outline of my talk is about the definition, the paradox in the matter, the importance of the early diagnosis, and the clues for proper diagnosis. According to Karimzadeh, neurometabolic diseases refer to a group of disorders that are characterized by a lack of dysfunction of an enzyme or vitamin necessary for a specific chemical reaction in the body, leading to disturbance of neurologic function or destruction of the nervous system. But if you pay attention to this definition, it looks that it is actually the second step of a cascade, usually beginning with a genetic problem. So we can categorize the neurometabolic disorders as a subgroup of genetic disorders leading to an enzyme deficiency and so producing the symptoms and signs or symptomatology of the neurometabolic disorder. And what's the paradox here? If you consider the prevalence and incidence of metabolic disorders individually. They are very rare disease, but if you collectively consider metabolic disease, it's not so rare. But the paradox here is that these rare events and disorders usually present as common neurologic disorders of the nerve. And it is a very great paradox. And we should pay attention to this paradox for proper diagnosis. How to overcome this paradox? First, pay attention to rare or unusual manifestations of the common disease. It's very important. For example, prolongation of the signs and symptoms despite appropriate intervention. For example, unresponsiveness to common anti-seizure medication. Uncommon manifestation in a common disease is very important. That's prolonged infection despite appropriate treatment, or severe acidosis, which usually do not respond to acid-base balance. And first, exclude common disease, very important. In other words, neurometabolic disorders, neurometabolic encephalopathies in the new world is diagnosis of exclusion. So pay special attention to important symptomatic clues. For example, some clues such as facial cortex in lysosomal diseases. And what is the important clues in history and examination for proper diagnosis? Pay attention to family history. It's very important. Usually you have not two cerebral palsy in a single family, for example, due to hypoxic ischemic encephalopathy. So families with more than one cases of cerebral palsy, or families with SIVs, with siblings with similar symptomatology, it's a red flag for us. Unusual symptomatology, for example, intractable seizure, severe unexpected signs for a common disease. Peculiar signs, such as persistent hiccups in a newborn, which could be a sign for non-ketotic hyperglycemia. And prolonged infections, and unusual responsiveness to antibacterial or antiviral treatments. Unexplained low output score, more in the favor of treatable cases of neurometabolic disease, is a very important point. There are some diets, trials, as well as tetrals, which are very important for diagnosis. For example, alopecia, triple excess nodosa, which is a good sign of symptomatology for argininosuccinate aciduria. And cataplexy with up-gaze palsy is a very good sign in Niemann-Pick type C. But consider that we are not usually presented in the neonatal period. And some triads, such as alopecia, diabetes, dermatitis, intractable epilepsy, which could be a very good symptomatology and sign for vitamin-based deficiency. What is the importance of the early detection? I have proposed a matrix, four-field matrix for this. Consider the first field, which is actually early detection and early intervention. Actually, this is the best field, which usually will be associated with near normal neurodevelopmental and neurological outcome. Let's go to the second field of the matrix. Early intervention without early detection is just a guess, just shut in the dark, and very low chance for normal development and normal success. and great success with global development and neurological outcome. The third field is early detection without early intervention. It is a great scene often. And the last field is this matrix is early detection, no early detection and no early intervention. I think this is worse field in neurologic and neurodevelopmental outcome. Look at this diagram, which shows treatable causes of neurometabolic encephalopathies in the newborn. You can see that treatable causes are very, very large, from protein defect disorders to urea cycle defects, and you can see this is a very long list of the treatable causes. So we should not be disappointed about the outcome of neurological or neurometabolic disorders of the newborn, and we should have a proper diagnosis for an early detection, for an early intervention. Let's have few words on encephalic crisis. You should consider that neurometabolic disorders are not always have a scenario of neurodegeneration. It's very important. It could be static, and sometimes it has a honeymoon period, and the stressors like viral illnesses trigger encephalopathic crisis. So if an infant, if a child has a normal development at first, we should not rule out neurometabolic disorders of infancy and the newborn. For example, glutaric aciduria could be associated with normal development. And if you have not any crisis, I mean any stressor, such as viral infection or other infections, during the first 7 years of life, you will have a near normal development. The other mistake, which is really common, is that we used to diagnose when there are several or multiple congenital anomalies. I mean, minor anomalies in an infant. We usually think that these are due to some chromosomal disruption. And it's not true always. You could have some phenotypic abnormality in the neurometabolic disorders, such as Zellweger syndrome, with a typical facial feature, and the pyruvate dehydrogenase deficiency, which would present as fetal alcohol syndrome with those anomalies seen in the fetal alcohol syndrome. And also Smith-Lemli-Opitz, which could be induced by metabolic disorder. And we should mind some diagnostic pitfalls dealing with the newborn or an infant with neurometabolic encephalopathy. These pitfalls are thinking that only large chromosomal disruption and not immoral metabolism could lead to dysmorphia. It's a very wrong idea. For example, pyruvate dehydrogenase deficiency could be, as I stated, could be like fetal alcohol syndrome. Smith-Lemli-Opitz syndrome could be induced by deficiency in 7-dehydrocholesterol reductase and could be improved by high cholesterol diets. Zellweger syndrome due to decreased peroxisomal function. And do not only try for further state exam or do further state. Sometimes pass the state is equally important, for example, in hypoketotic hypoglycemia. And the last lesson to be learned from this short talk is that metabolic encephalopathies are individually rare conditions, but collectively they are not. Rarity versus commonality is a paradox, is a peculiar feature of these diseases. Although they are very rare, but they can present as very common disorders of early infancy and neonatal age. High level of suspicion is very important and is the cornerstone of diagnostic process. And paying attention to diagnostic clues in medical history and clinical examination is very important for early diagnosis and proper diagnosis. The stressors are very important as well to develop full clinical story, and we should always pay attention to deviators and pitfalls in diagnosis. Thank you so much for your attention, and I will pass to Zahra for the results of the case presentation that she had. Thank you so much.
Great presentation, dear Professor Mohammadi. Mariam, is my screen shared again?
Yes, we can see it.
Okay. Thank you, Professor Mohammadi, for sharing your knowledge and expertise with us. Okay, let's back to cases. Do you remember the first case? You could review the slides quickly. What are you thinking about the neonatal abstinence syndrome now? Neonatal abstinence syndrome could be caused by use some substances during pregnancy or before delivery that are listed in the slide. In the first case, there are some clues to make the accurate decision and to make the correct diagnosis, such as low birth body weight. I mean, for example, less than 2050 grams. No appropriate pregnancy care means that maybe gestational diabetes or glucose intolerance were not detected in mother during pregnancy. Substance using make the pregnancy high risk by itself, and ritodrine hydrochloride that was prescribed to prevent preterm labor is a beta agonist tocolytics, could lead to hypoglycemia. And finally, signs and symptoms, however non-specific, are in favor of hypoglycemia. Here, ABM clinical protocol revealed clinical manifestation of hypoglycemia in neonate, such as irritability, tremor, jitteriness, tachypnea, sweating, pallor, and so on. As you can see the signs and symptoms, they are non-specific, and you should consider different diagnoses in mind. And the protocol shows maternal and neonatal risk factors of hypoglycemia, such as substance abuse and treatment with beta agonist tocolytics in mother, and, for example, low birth weight or infants of poorly controlled diabetic mothers, prematurity, and so on as risk factor in neonates. By considering permanent damage of hypoglycemia in a vulnerable neonatal brain, high index of suspicion, early detection, and early intervention are critical. And how about the second case? Just several seconds to review the history if needed. What are you thinking about the clues of this case? Onset of seizure, very early onset of seizure in neoclinic presentation, consanguineous background, and signs and symptoms lead to more advanced workups. The electroencephalography of the infants shows birth suppression pattern, as you could see the red and the blue arrows respectively. And amino acid chromatography shows high plasma and CSF glycine level. CSF to plasma glycine ratio was high too. Brain MRI shows bilateral abnormal signal intensity as well as restriction at posterior limb of internal capsule. Timing of corpus callosum indetectable as well. Here we can see other brain MRI findings that could be detected in such patients. For example, agenesia or dysgenesia of corpus callosum, diffuse hypomyelination, ventriculomegaly, or posterior fossa abnormalities, cerebellar abnormalities are reported too. And finally, genetic study. A genetic study detected a pathogenic homozygous AMT variant in patients that was confirmed by segregation as heterozygous variant in parents. Classic non-ketotic hyperglycemia could occur due to GLDC, AMT, and GCSH mutations. Here, glycine cleavage system is illustrated, and the three previously mentioned variants I highlighted in red, green, and blue boxes. AMT variants that was detected in our patients are mentioned separately. And here we can see the last laboratory data of the patients. As you could see, a high level of glycine is noted as well. Consanguineous background, early onset refractory myoclonic seizure, frequent hiccups even during pregnancy, in fetus, and encephalopathy are clues in favor of metabolic or inherited etiology. Ancillary appropriate evaluations such as electroencephalography, serum or CSF amino acid chromatography, brain imaging, and genetic study could lead to accurate diagnosis. And the third and the last case, to rapid review the data, take a look at the slides, please.
Dr. Rezai? Oh, yeah, okay.
Is there any problem, Mariam?
No, I just couldn't see the case number 3, but now it is visible. Okay.
Okay. And do you believe that the twin are suffered from hypoxic ischemic encephalopathy? We can review the brain MRI again. Okay, early onset refractory seizures, consanguineous background, no obvious insult after birth, and brain MRI findings make significant clues. Hypoxic ischemic encephalopathy is a common cause but not the only cause of neonatal encephalopathy. Laboratory data in our patients shows that increased level of sulfate, thiosulfide, sulfocysteine, taurine, xanthine, hypoxanthine, irrespective of decreased level of serum uric acid. And genetic study revealed a pathogenic homozygous mutation in MOCS2 variant, MOX2, that was confirmed in the another twin and parents 2. So, molybdenum cofactor deficiency with MOCD abbreviation is the diagnosis. The most frequent variants responsible for the disease are listed here: MOX1, MOX2, GEPH, and MOX3. They are mentioned in order of frequency. I mean that MOX1 is the most frequent variants could lead to molybdenum cofactor deficiency. And the metabolic pathway of amino acid and responsible enzymes are illustrated here. So metabolites changes are more perceptible now. Isolated sulfate oxidase deficiency with a similar clinical and imaging manifestation is the main differential diagnosis. Biochemical analysis could be helpful here. Intractable seizure presented in the first few days of life, hypertonia, feeding difficulties, abnormal faces such as puffy cheeks, lying face, microgynecia, large ears, and microcephaly are the main clinical manifestations of these patients. And here you can see the last brain MRI of our patients. Brain MRI shows cystic encephalomalacia, abnormal white matter signal changes, and tightening of corpus callosum. These features could easily be misdiagnosed and misinterpreted as hypoxic ischemic encephalopathy. And unfortunately, a 12 months gap for diagnosis is reported again. Consider hypoxic ischemic encephalopathy differential diagnosis if clinically indicated by following the clues carefully. I'm going to summarize the points. Seizure is a common presentation in neonatal metabolic encephalopathy. Consider common and serious etiology in neonatal encephalopathy at first. Neonatal metabolic encephalopathy is not as common as hypoxic ischemic encephalopathy. High suspicious index, early detection, and prompt intervention are vital. And keep in mind that all glitters is not gold. I appreciate all participants for engagement and interest in the webinar. Thanks for staying with us. All comments, feedback, and questions are warmly welcomed.
Thank you, Dr. Rezai, for the amazing presentation, and also Dr. Mohammadi. So I learned a lot from you as usual and as before. So maybe we can have a quick time to review if there are any questions in the chat box. But before we get through that, I actually had a few questions myself. So Dr. Rezai, I really wanted to know, so regarding the cases that you were discussing here, so is there any treatment or any management that is available right now?
As I stated and you saw in my slides, there are many causes of treatable neurometabolic disorders in infancy. And the key for normal neurodevelopmental outcome is early diagnosis. Early diagnosis And in some cases, you can, because as you know, especially for small molecule disorder, disease of the neurometabolic disorders, you have A compound changing to B and catalyzed to C. So if you, it seems like, but it is quite, it's quite simple, but it is a very good example. If you, for example, limit the intake, it's some kind of treatment. And if you can produce or if you can compensate for the C compound, it's a type of treatment for this, a type of small molecular disease in neurometabolic disorders. So early detection, I think, very important. Although you cannot always treat all the metabolic disorders, and we need time to know better the etiology, especially the genetic etiology of the neurometabolic disorders and genetic engineering and something like that to treat the better treat the neurometabolic disorders.
Okay. Okay, so thank you, Dr. Rahamadi. I also had another question from you, actually, myself. So I really wanted to know, is there any, for example, any specific EEG pattern that we can see that could lead us to these cases, could help us with the diagnoses?
As Zahra stated in the slides, neurometabolic disorders are like a puzzle, and every piece of puzzle has its role. You have not very specific part of the puzzle to diagnose the disorder. You should put it together to see what's the result and what is the ultimate picture of this scenario. And so there is no specific, no pathognomonic EEG finding. You can see some, for example, some patterns in some disorders, more in some disorders, but they are not specific. For example, birth suppression pattern. You can see birth suppression pattern in some neurometabolic disorders, from urea cycle defect, other types of metabolic disorders, and some other findings such as code-like rhythm, for example, in maple syrup urine disease, but they are not specific, and you should not emphasize only in one part of one piece of this puzzle.
Okay, I get that. Thank you so much. Thank you. Okay, so I see a few questions in the chat box, so I will read them, and whichever of you would love, we would love to listen to your response. So the first question that I'm seeing is that, okay, so before going to that, I forgot to mention this. So for people, if you want to attain your credit and also your CME credit, you can use the code that is provided here, and the code will also be emailed to you after the session is over. So don't forget to scan or apply this QR code and the code. Okay, so back to the questions. So the first question that I'm seeing here is that what is the basic biological and imaging in this situation?
Let's ask what do you mean by basic? It's very important.
Mm-hmm.
What do you mean by basic here?
So maybe they mean...
Maybe the question is referred to a specific situation, I think.
Mm-hmm.
Can you repeat the question, please?
Yes. So the question is that what is the basic biologic and imaging in these situations? I think we covered this in the talk. So I don't know if they could maybe explain more about the question. I would get back to the question after that. Okay. So I will go to the next question right now, is that please elaborate on the time of the onset of these infantile metabolic encephalopathies.
There are different time of onset of the symptoms. As I stated in my slide, you usually have a honeymoon period for neurometabolic disorders. And but some of these disorders have very early onset, as hypoxic ischemic encephalopathy, and some of them have a very longer onset period, for example, in the second, third decades. So you cannot say that every neurometabolic disorder usually start at the beginning of the life in neonatal period.
Mhm. Okay, thank you. So the next question that I'm seeing in the chat box is that what is your opinion about genetic testing for all patients with metabolic symptoms? And what is the best genetic test for these patients?
As you know, we are practicing medicine in different countries and different regions in the world. And in some regions, we are really source limited source. We have limited source. So we should have a cost-benefit analysis on tests and exam requesting for the patient. For example, if you can diagnose a neurometabolic disorder for only by studying the enzyme or by having MRI and putting together to reach the final diagnosis, in a source-limited country, it is enough. But if you have the possibility to test for genetic studies, which are more expensive, and you should have a clinical geneticist along beside you to diagnose and to consult the patient, it is better to have a genetic study. So it depends on where you are practicing your medicine.
Mhm. And also, Dr.
Mariam,
Ma, yeah, go ahead. Yeah, go ahead.
Yeah. In order to completing the Professor Mohammadi's comments, there are some rapid sequencing genetic study in some neonatal intensive care units. Obviously, not in resource limited countries, and they could check the most frequent genes that are responsible for metabolic, inherited, or for example, the developmental epileptic encephalopathy in neonates, and the answer the genetic result will be ready, for example, in 2 or 3 weeks, very soon, and it could be helpful to make the best management in the neonatal unit.
And
Okay.
I should insist on the patient education. As Zahra stated, as Zahra said, to reach a final diagnosis needs time. And during time, the family is so anxious about the patient. And having a patient education, parents education is very important to reach diagnosis and to final outcome. Because compliance is very important. And when you have a very good patient education, you will elevate the compliance of the parents and patients. For having a better diagnostic test and also treatment.
Okay, well, thank you for clarifying that. So the next question that I can see, I think it is a comment mostly, but it's saying that, what about homocysteine level in molybdenum cofactor deficiency? So I'm guessing that maybe they're commenting that we should also consider that in these cases.
Yes, I will share my screen again.
Yeah, thank you.
To illustrate, yeah. Here you can see the metabolite pathway of cofactor molybdenum deficiency, and as you see, homocysteine level is decreased in the disease, both in sulfite oxidase deficiency, isolated sulfite oxidase, and in cofactor molybdenum deficiency. If you could have a look at this illustrated metabolic pathway, I think that the metabolite changes are more sensible for you.
Okay, so thank you. So the next question that I see is that, is there any specific seizure pattern in these conditions? And I think this is the question I asked myself from Dr. Mohammadi about the EEG pattern, and you told me that there's no specific pattern. We could see burst suppressions, but this is just like a puzzle, and we have to put together pieces